Bismillahirrahmanirrahim. This video will describe the variants of rheumatoid arthritis such as juvenile idiopathic arthritis and seronegative spondyloarthropathies. The references for this video are these. Variant form of the rheumatoid arthritis are Bell-Feltis syndrome, juvenile idiopathic arthritis, which is also termed as GIA, and seronegative spondyloarthropathies. This Feltis syndrome is polyarticular rheumatoid arthritis associated with splenomegaly, hypersplenism, and consequent hematological derangements. The juvenile idiopathic arthritis is also termed as Still's disease. About 30 to 50,000 cases in the US have been reported. It is a heterogeneous group of disorder of unknown etiology that presents with arthritis before the age of 16 years and persists for at least 6 weeks, less than 16 years and 6 weeks. So the Still disease or GIA is a large joint disorder of female lead to functional disability. However, rheumatoid nodule and RF factor are absent. There are some differentiating features of this GIA from rheumatoid arthritis. These are that oligoarthritis is more common, systemic disease is more frequent, large joints are affected more, and ANA seropositivity, anti-nuclear antibody, is common. However, it resembles with the rheumatoid arthritis in certain aspects, such as its association with certain HLA types. Then, the inflammatory cells which are involved, such as Th1 and Th17, and inflammatory mediators, interleukin 117, gamma interferon, and TNF, are involved in the pathogenetic process. So, depending on the clinical and laboratory features, juvenile idiopathic arthritis is subclassified into systemic arthritis, oligoarthritis, RF positive and RF negative polyarthritis, Enteritis-Associated arthritis. Enthesis is the area in the bone where ligament or cartilage is inserted. So, if there is inflammation of that area, that is Enteritis-Associated arthritis, then psoriatic arthritis, and undifferentiated arthritis, which cannot be fitted to any of these category. The risk is associated with genetic susceptibility and other environmental factor. As we have seen that the disease is heterogeneous, and this indicates that many factors play their role in the causation of the disease. Morphological features are similar to that of rheumatoid arthritis, and there is significant evidence of the abnormal immunoregulation and prevalence of activated CD4 plus memory T cells in the joint, and cytokine production is prominent, and cytokine production is the basic phenomenon which regulate the process, or which drive the process rather. So treatment for this juvenile idiopathic arthritis is similar as for rheumatoid arthritis, and systemic interleukin-6 receptor antibodies are also being implicated in this disease. Prognosis is variable, however 10% of the people they develop disability. The polyarticular disease with systemic symptoms affect 20% cases of the GIA. This disease is abrupt in onset and associated with spikes of high-grade fever, migratory skin rash, lymphadenopathy, hepatosplenomegaly, serositis, anemia, and leukocytosis. The people may experience recurrent flares of persistent disease, and it results in significant morbidity. Long-term prognosis of this entity, 10% have they develop serious functional disability, and 25% develop severe disease. The most common category of GIA is oligoarthritis variant, which is also termed as polyarticular variant. It affects more than 50% of the people affected by the GIA, and it affects 4 or less than 4 joints during first 6 months of the disease in the absence of psoriasis or an HLA-B27G type genotype. The arthritis is asymmetric and develops at an early age. The mean age is less than 6 years. The arthritis is commonly associated with iridocyclitis, which is inflammation of the iris and ciliary body, and frequently it is positive with antinuclear antibody. The rheumatoid factor associated polyarthritis or seropositive polyarthritis affects less than 10% of the individual, and it's similar to the adult form of the rheumatoid arthritis, but it is seen mainly in the teenage girls. HLA-D4 is also present in this. Rheumatoid factor negative polyarthritis also affects less than 10% of the people. It affects more than 5 joints within the first 6 months, and it consists of several subtypes that have features that overlap with oligoarthritis and rheumatoid factor negative arthritis in adult, and is a subset that shows stiffness and contraction but little swelling. More than 50% of these people who develop rheumatoid factor negative polyarthritis, they develop severe type of the arthritis. The Enteritis-Associated Arthritis commonly affect male children, and age of onset is less than 6 years. HLA-B27 is positive, and there is arthritis effect mainly at the site of insertion of the ligament on the joint. Then there is the final category, undifferentiated arthritis. The people who are not fulfilling any inclusion criteria in the other group and they have got overlapping features, then they are labeled as undifferentiated arthritis. Seronegative spondyloarthropathies are a group of disease that develop in genetically predisposed host and are initiated by ubiquitous environmental factors, especially infectious agents. The characteristic of these arthropathies are the absence of rheumatoid factor, hence these are termed as seronegative. The pathological changes are mainly in the ligamentous attachment rather than the synovium. Sacroiliac joint is commonly affected. There is association with HLA-B27. Bony proliferation leads to ankylosis, and these arthropathies are frequently associated with extra-articular manifestations which can be seen in eye, skin, and central and cardiovascular system. The entities which are included in the seronegative spondyloarthropathies are ankylosing spondylitis, reactive arthritis, psoriatic arthritis, and arthritis associated with inflammatory bowel disease. Ankylosing spondylitis, which is one of the seronegative spondyloarthropathy and is also termed as rheumatoid spondylitis and Marie-Strümpell disease, is a chronic synovitis that causes destruction of the articular cartilage, and it results in bony ankylosis, especially of the sacroiliac and apophyseal joints. If there is inflammation of the tendinoligamentous insertion site, it results in their ossification and produces squaring and fusion of the vertebral bodies and bony outgrowth. Together, these two lesions result in severe spinal immobility. The onset of disease is between 20 to 30 years of age. Then it is about twice as common in men than in female. The patient presents as asymmetric low back pain and spinal immobility. The frequently affected joints are sacroiliac, hip, knee, and shoulder joint, which are affected in about 1/3 of the cases. The pathogenesis of this disease is linked with the HLA-B27, which is present in more than 90% of the cases. The HLA-B27 role is not clear, though it is linked with the antigen processing and presentation to trigger the disease. Recently, uh, ARTS1 gene that encodes a peptide that triggers the antigen being processed for the presentation by class 1 HLA molecule is linked with this disease. Also, interleukin 23 receptor gene are also associated with this disease, as it is thought that this interleukin 23 promotes T helper 17 responses. And the complication of this disease are fracture of the spine, uveitis, aortitis, and amyloidosis. Ankylosing spondylitis symmetrically affects sacroiliac joints and then involve small joints of the posterior element of the spine. Due to resultant destruction, a spine fuses posteriorly, then vertebral bodies become square, as shown in this cross picture of the vertebral column, which is cut vertically to show the square shaped vertebral bodies and fusion of the bone bridges. Later on, the intervertebral disc ossifies and intervertebral disc then disappear or can be replaced by the bone marrow. There is osteoporosis of the vertebral bodies also due to disuse atrophy. This ankylosing spondylitis is a crippling disease, but there is no effect on the lifespan. So sacroiliitis is the common feature of these ankylosing spondylitis. Here you can see that in this radiograph, the sacroiliac joints are inflamed and narrowed, and they are more wide due to bony sclerosis around the joints. Microscopically, the ankylosing spondylitis is characterized by chronic synovitis and fibrosis. There is destruction of the articular cartilage also. All these result in the bony ankylosis. This X-ray is showing the tendinoligamentous ossification and some bony outgrowths. This slide is summarizing all the events of this ankylosing spondylitis we have discussed so far. There is inflammation and subsequent resultant fusion or ankylosis of the joint. Another member of this seronegative spondyloarthropathy is reactive arthritis, which was previously termed as Ritter's syndrome. This is the triad of arthritis, non-gonococcal urethritis or cervicitis, and conjunctivitis following an infection. The arthritis in this entity can be mono or oligoarthritis, and it occurs days to week following genitourinary or gastrointestinal infection. HIV is also associated with this reactive arthritis. Then pathogenetic mechanism for this entity is autoimmune reaction, because 80% cases are positive for HLA-B27. Prevalence of this disease is 30 per 100,000 adult. Men in their 20 or 30s with arthritic symptom following urethritis or diarrhea, and this arthritis is this arthritis involve ankle, knee, and feet asymmetrically with low back pain and joint stiffness. Repetitive episode for about 6 months, and 50% of the patient have recurrent arthritis, tendinitis, and lumbosacral pain. If the disease persists for more than 6 months, this is termed as chronic reactive arthritis. Spondyloarthritis and spinal involvement are indistinguishable from the ankylosing spondylitis. It is associated frequently with the enthesitis, in which infrequent site is Achilles tendon and calcaneal plantar fascia, which result in heel swelling. Dactylitis will result in sausage-like digits. Low back pain is also seen. Joint stiffness, digital tendon sheet synovitis will result in sausage finger or toe. Spur is formed and is common in calcanea. Extraarticular involvement is conjunctivitis, uveitis, dysuria, pelvic pain, urethritis, balanitis, cervicitis, mucosal ulcer, and cardiac valvular abnormality, which result in aortic insufficiency. And there are some cutaneous manifestations also, such as skin rashes, psoriasis, like nail. Enteritis-associated arthritis is one of the seronegative spondyloarthropathy, and these present with abrupt onset arthritis of knee, ankle, wrist, finger, and toe, and it lasts for about 1 year and then generally subsides, and it is rarely accompanied by ankylosing spondylitis. The psoriatic arthropathy or psoriatic arthritis is present in about 7% of the people with psoriasis. Disease is mostly asymptomatic but can be painful, and initially the interphalangeal joints of hand and feet are affected, and later on more joints are added of ankle, knee, hips, spine, and wrist. Microscopic features are almost same as that of rheumatoid arthritis. Arthritis with inflammatory bowel disease, that are the Crohn disease and ulcerative colitis, affects 20% of the cases of inflammatory bowel disease. HLA-B27 and protein from the enteric bacteria, they are structurally related in a manner that affects antigenic presentation to the T cell receptor, hence are responsible for the progression of this arthritis. Severity of the arthritis symptoms depends on the extent of the bowel disease, and beside the joint, other areas of the body which are affected by the by the inflammatory bowel disease are ankle, knee, bowel, liver, digestive tract, skin, eyes, spines, and hips.